Good morning, Mr. President. We're almost ready to go live. We're just checking on webcast to be sure that, and we'll give you a heads up. Thank you. Mr. President, the webcast is on, so we could start when you're ready.
Okay. I call to order the informal interactive multi-stakeholder hearing as part of the preparatory process for the 2021 high-level meeting of the General Assembly on HIV/AIDS. This meeting is held in accordance with paragraph 8 of Resolution 75/260 of 23rd of February 2021. I warmly welcome you all to this meeting. The interactive hearing provides all relevant stakeholders an opportunity to contribute to the ongoing high-level meeting preparations through interactive panel discussions. The hearing aims to support member states with the preparatory process, including to inform the negotiations on the declaration of the high-level meeting, through an interactive dialogue with communities, civil society, and other key stakeholders. During the panel discussions, civil society representatives and other stakeholders are expected to share their views and experiences from their work on the ground. The hearing also aims to demonstrate the strength, diversity, and commitment of communities, civil society, and other stakeholders in the response to the HIV/AIDS epidemic, and to propose actions that will make it possible to upend intersecting inequalities that are preventing progress to achieving zero new HIV infections, zero AIDS-related deaths, and zero discrimination, and ending AIDS as a public threat by 2030. I'll make my opening statement now. Excellencies, Her Excellency Winnie Byanyima, Under-Secretary General and Executive Director of UNAIDS, dear friends, it is my pleasure to welcome you to this multi-stakeholder hearing on HIV/AIDS in advance of the high-level meeting, which will take place from June 8th to 10th. At the outset, can I thank the co-facilitators, Ambassador Neville Gertz of Namibia and Ambassador Mitch Fifield of Australia, and their teams for ably steering this process. I also thank Her Excellency Winnie Byanyima, Under-Secretary General and Executive Director of UNAIDS, and her team for the invaluable work and support to the co-facilitators and the Office of the President of the General Assembly. Furthermore, I wish to acknowledge the work of the Multi-Stakeholder Task Force for their tireless efforts in preparation for this hearing. I also thank you for joining us here today. Your participation here today is not taken for granted. I understand that many of you began advocating and organizing after experiencing loss, suffering, discrimination, and marginalization. I commend you for sharing your lived experience in order to create a better world for all. Your resilience is unmatched. I trust that today's hearing will provide you with an opportunity to engage with others, to exchange ideas and best practices, to be seen, to be inspired, and to find the strength to continue your efforts, for we cannot do this without you. I urge all member states to engage constructively in the informal consultations on the outcome of the high-level meeting. If there is one thing we have learned this past year, It is the precious value of health in all its dimensions. Dear colleagues, you understand the complexity and intersectionality of living with HIV, making you best placed to advise policymakers on how to create legal and social environments that uphold fundamental human rights and protect people from HIV. Your work in communities, bridging divides and filling existing gaps is more important than ever as we navigate the COVID-19 pandemic, where service disruptions have hampered efforts to reduce new infections and AIDS-related mortality. 4 decades on from the first detected case of HIV, we have made great strides towards ending AIDS. Our collective efforts have saved lives. Fewer people are dying of AIDS. Fewer children are born with HIV. And thanks to antiretroviral treatment, there is far less suffering in the world. Yet we have not met the targets set out for 2020, which aim to fast-track the HIV response. The most vulnerable are hardest hit by HIV. Around the world, those who have been marginalized, migrants, and people trapped in humanitarian crisis are bearing the brunt of this disease. Of the 1.7 million people who acquired HIV last year, 280,000 were adolescent girls and young women, with thousands more becoming newly infected with HIV each week. Now is our last chance to switch into a higher gear. We must take urgent action to ensure equal access to treatment if we are to prevent the 12 million people living with HIV from dying of AIDS-related causes. I call on all United Nations member states to make this year a decisive turning point in the response to the HIV epidemic. The world can end AIDS as a public health threat by 2030. I ask member states to adopt an ambitious, inclusive, and bold political declaration that advances the decade of action to implement the Sustainable Development Goals. We need to work together to prevent 1.7 million new HIV infections each year, and to ensure that 12 million people living with HIV have access to antiretroviral treatment. Failure is not an option. I thank you for your time, and I wish you well for a productive day ahead. I now give the floor to His Excellency Neville Gertz, Permanent Representative of Namibia to the United Nations and co-facilitator on the preparations for 2021 high-level meeting on HIV/AIDS, to make a statement.
Your Excellency Volkan Bozkır, President of the General Assembly, Madame Winnie Byanyima, Executive Director of UNAIDS, Excellencies, ladies and gentlemen, good evening, good afternoon, and good morning from wherever you are watching or participating today. I am indeed pleased to address this forum in my capacity as a co-facilitator for the preparatory processes for the high-level meeting on HIV/AIDS. I would like to thank everyone for joining this important forum today and for their valuable role in providing support to people living with, at risk of, and affected by HIV and AIDS. Your efforts at all levels aimed at bringing the AIDS epidemic to an end as a matter of utmost priority is profoundly appreciated. We must stand together in the fight to achieve zero new HIV infections, zero AIDS-related deaths, zero discrimination, and ending AIDS as a public health threat by 2030. Since the HIV/AIDS epidemic first emerged in the early 1980s, approximately 76 million people have become infected with HIV, and 33 million people have died from AIDS-related illnesses. In the 40 years since the first reported case, there have been many gains in the fight against HIV. In 2016, HIV/AIDS was dropped from the list of the top 10 leading causes of death identified by WHO. By the end of 2019, approximately 25.4 million people were accessing antiretroviral therapy. However, significant challenges remain. The world has not met the 2020 targets we set ourselves in the political declaration for the 2016 high-level meeting. COVID-19 has further threatened existing progress as health services, resources, and investment are diverted. The COVID-19 pandemic has exposed the inadequacy of investments in public health, the persistence of profound economic and social inequalities, and the fragility of many key global systems and approaches. This latest global health emergency, however, also offers historic opportunities. We must address these dual epidemics not by taking away from the HIV response for the COVID-19 response, but rather by being agile and innovative to support the continuation of HIV services while also appropriately leveraging and expanding on key elements from HIV. By taking on board lessons learned through HIV, fighting COVID-19 can aid in reimagining systems of health to accelerate the health-related commitments of the 2030 Agenda for Sustainable Development. At the same time that the HIV experience helps to inform COVID-19 responses, the unfolding response to the COVID-19 pandemic will undoubtedly yield lessons that can benefit both the HIV response as well as broader efforts to strengthen health systems. Civil society forged the initial response to HIV and AIDS within a rights-based paradigm and built international networks. As the fight against HIV and AIDS shifts from an emergency response to a long-term response, the role of civil society organizations, including community-based, non-governmental, and faith-based organizations in HIV and AIDS prevention, care, and support efforts becomes even more important. Civil society plays a critical role in HIV and AIDS, advocacy, and service delivery. The interactive multi-stakeholder hearing provides an opportunity for civil society organizations and other relevant stakeholders to contribute to the ongoing high-level meeting preparations through interactive panel discussions by sharing their views and experiences from their work on the ground. We look forward to listening to your views and your input today. The HIV/AIDS movement has a strong history of mobilizing political engagement. This year's meeting is no different and is an important opportunity to take stock of our achievements and the gains that must be protected if we are to end the AIDS epidemic by 2030. As we embark on the process to come up with a political declaration that is ambitious and cognizant of the gaps present in the global AIDS response, we look forward to including the voices of civil society. I wish this meeting today the very best, and all of you the best in your deliberations, and I thank you, Mr. President.
The inspiring statement. I now invite Ms. Winnie Byanyima, Executive Director of the Joint United Nations Programme on HIV/AIDS, to make a statement.
Your Excellency, Mr.
Bu şey değil mi? Etiyopyalı. Ugandalı.
Can you hear me? Can you hear me? You can hear me? great. Thank you. Your Excellency, President of the General Assembly, Mr. Boskill, Your Excellencies, co-facilitators, Mr. Goetze and Mr. Fifield, thank you for your strong dedication in organizing the high-level meeting on HIV/AIDS and this interactive hearing. Excellencies, distinguished participants, my friends, HIV activists, the COVID pandemic prevented us from being in person in New York, but it will not prevent us from raising our voices together to discuss the future of the AIDS response. I'd like to start by acknowledging the work of the Multi-Stakeholder Task Force for the organization of this event. Since the first years of the pandemic, it was the loud and persistent voices of people living with HIV and the communities most affected who accelerated the pace of progress. I know that communities are uniquely positioned to reflect on the successes and challenges and make recommendations for the future of the HIV global response. We are here to listen and to learn from you. And that's why I thank very much the President of the General Assembly for making it happen. I'd like to acknowledge the representatives of civil society, the private sector, member states, and the United Nations that are here with us. Strong leadership at all levels of society is essential for an effective response to the epidemic. After more than 1 year, the COVID-19 pandemic has changed our world immeasurably. The pandemic continues to have a devastating impact, especially on those most marginalized. We hope that the sense of urgency moving the world to find solutions to COVID-19 also reignites the urgency to address the unfinished business of the HIV pandemic. This year, as you've heard, marks 40 years since the first cases of AIDS were reported and 25 years since the establishment of the United Nations Joint Program on AIDS. It is global solidarity, scientific innovation, and community resilience that have saved millions of lives. Despite this progress, the AIDS pandemic remains a global crisis. Nearly 700,000 people die of AIDS every year, and 1.7 million people acquire HIV. In 2021, every one of these infections and deaths is preventable. We know how to end AIDS. The world missed the global targets that were committed to in the 2016 political declaration. And why? Because inequalities are a key reason for this failure. It's unacceptable that Africa remains the epicenter, with adolescent girls and young women 5 times more vulnerable than boys and men of the same age. Inequalities leave key populations facing the majority of new HIV infections globally. All this is unacceptable. It's preventable. The struggle to end AIDS is inextricably linked with the struggle to end human rights violations, including discrimination and violence against women and girls, as well as the marginalization and criminalization of people living with HIV and of key populations. And who do we mean by key populations? It's sex workers, it's people who use drugs, it's gay, bisexual, and other men who have sex with men, and it's transgender people and other groups like prisoners. In March, the UNAIDS Program Coordinating Board adopted a new 5-year global AIDS strategy focused on addressing the inequalities that drive HIV infections and deaths. If we achieve the targets in the strategy, we will dramatically reduce HIV infections and AIDS deaths by 2025, and we can then end the AIDS epidemic by 2030. 20 years have passed since the historic United Nations General Assembly special session on AIDS. Now is the moment for world leaders to commit to getting the world back on track to end AIDS and to ensure that the 2021 political declaration on HIV is ambitious, is progressive, and is innovative. Let's work together, partnering with the affected communities to end inequalities and to end AIDS. I thank you, Mr. President.
I thank the Executive Director of the Joint United Nations Programme on HIV/AIDS for her statement. I now give the floor to Ms. Faith Ebere-Onu from the Association of Positive Youth Living with HIV and AIDS in Nigeria.
Distinguished delegates, member states, members of civil society, and communities everywhere. Good morning, good afternoon, good evening, everyone from everywhere you are watching this. My name is Faith Ebere-Onu. I'm from Nigeria. It is my pleasure to address you at the opening of this hearing. Today, as a young woman living with HIV, I have the privilege to address you at the opening of this hearing. On behalf of 38 million people living with HIV, I want to speak on their behalf. I am a Nigerian, and we are known for our proverbs. I bring an old saying with a new twist. Individually, we move fast.
Bizim söylemek istediklerimiz aynen okumuş. Nasıl olmuş o?
Together we go far, and united we can end this epidemic.
Hello, everybody. Good afternoon. This is UNDSS.
We are all gathered here today for one common purpose, and that is to end the AIDS epidemic by 2030. As a young person, I have learned in my time living with HIV and working with my community that in order to reach this target of ending AIDS by 2030, we must work together as a global community. While as various individual member states, we may be making progress globally. Globally, we are still off track. And some regions like mine, West and Central Africa, continue to lag behind. Progress on HIV have not been equal. Not equal between countries and not equal between communities. This reality became clearer from the onset of COVID-19 pandemic last year, and we continue to see it even in how it is managed. Many countries in Africa are yet to even have one person access to the vaccine. While I stand here as a young woman living with HIV, I think of my colleagues and peers, the young gay and bisexual men, the young sex workers, the young people who use drugs, the young transgender people, the young people in custodial settings, and young people in humanitarian and fragile settings who are still impacted by stigma, discrimination, laws, and policies that make their very identities taboo and illegal in their countries. I think of many young women like me who still do not have access to sexual and reproductive health and rights, such as safe abortion, and in particular adolescent girls who may not even be able to have access to HIV tests because of restrictive age of consent laws. As young women, we remain exposed to violence, harmful cultural practices, and exposure to HIV. I humbly ask that all delegates and global health actors here today make a sound commitment about protecting the next generation from HIV. I was born with HIV 21 years ago. My mother may have lacked the knowledge of supporting or protecting me from getting it. But it is unfortunate that all these years later, globally, only 53% of the 1.8 million children living with HIV are on life-saving treatment, and 690,000 have died of AIDS-related illness in 2019. If we cannot stop the HIV epidemic in children and adolescents, how can we possibly stop the epidemic from anyone else? Women, especially adolescent girls and young women, need access not just to HIV prevention and treatment, but sexual and reproductive health services that both empower us and protect our health. We must support our pregnant women before, during, and after pregnancy and ensure that our children living with HIV get the medicine they need so that mothers and their children live well into the future. While we commend member states on the bold commitment that were made in the 2016 political declaration, it is clear that this has not been met. And progress has been further impeded by COVID-19. We young people in particular have been severely impacted by the results of the pandemic. Majority of us are currently affected by stockouts in our countries that make it impossible to access prevention, testing, and treatment interventions. Effectively addressing the AIDS epidemic will require sound leadership in addressing other existing as well as new epidemics. One shouldn't be at the expense of another. We also call on member states to prioritize investment in more holistic aspects of HIV prevention, ensuring education, particularly comprehensive sexuality education and gainful employment, social protection, and climate justice are all actions that must be taken in order to ensure that not only we end AIDS by 2030, but we ensure that the post-COVID world is one that is just and respects human rights of all people, and including particularly people living with HIV and young key populations. Today, there are too many laws and policies that actively work against young people, key population, and women that not only directly impede their access to HIV prevention, testing, and treatment, but also wider laws that criminalize identities and practices drive the HIV epidemic. Age of consent laws that put a barrier on young people to have access to HIV testing and treatment and harm reduction services will not end HIV transmission. Laws criminalizing sex workers, drug users will not end HIV transmission. Sexual and gender-based violence against women and minorities will not end HIV transmission. I stand here before you today, distinguished delegates, as my bright future depends on your decision, asking that you commit in helping us. Please, for us to end this AIDS by 2030, we need to repeal punitive laws to empower and fund community-led responses and to ensure a fair and just economic global health transformation from the devastation that COVID-19 has caused. In closing, I'm calling on member states present today and who will attend the high-level meeting in June to listen to me, listen to us, and listen to communities. When we tell you what we need to combat HIV, I confirm the commitment of people living with and at risk of and affected by HIV, represented through various networks and civil society organizations joining today across the world to work with you all to realize the targets made in the global AIDS strategy, mostly because to us, these are not just targets, they are our lives. As I said, my future depends on your decision. Today, we are here to express our needs and inform you of our decision. Please, thank you, and stay safe, everyone.
I thank Ms. Verona for her statement. As indicated in the program, this interactive multi-stakeholder hearing also consists of 4 panel discussions and a closing segment. The first panel discussion, entitled Equitable and Equal Access to HIV Prevention, Treatment and Services, will be moderated by Mr. Prasada Rao, former Special Envoy of the Secretary General of the United Nations on HIV/AIDS for the Asia-Pacific region, and will take place immediately following this opening segment. The second panel discussion, entitled Structural and Social Barriers to Achieving HIV Outcomes, Zero New HIV Infections, Zero AIDS-Related Deaths, and Zero Discrimination, will be moderated by Ms. Mirta Ruiz-Diaz from the Latin American and the Caribbean Movement of Positive Women, and will take place from 10:45 a.m. to 12 p.m. The third panel discussion, entitled Fully Resource and Sustain Efficient HIV Responses and Integrate into Systems for Health, Development, Social Protection, Humanitarian Settings and Pandemic Responses, will be moderated by Ms. Felicita Hikaum from the AIDS and Rights Alliance for Southern Africa and will take place this afternoon from 3 to 4:15 p.m. The fourth panel discussion, entitled Bringing It Together, Building Synergies and Addressing Critical Gaps, will be moderated by Ms. Oratila Moseki from Frontline AIDS and will take place from 4:15 to 5:30 p.m. The closing segment will take place immediately thereafter, moderated by Ms. Tegenbrink, the Chef de Cabinet of the Office of the President of the General Assembly. The opening segment is now concluded.
Excellency, President of the General Assembly, Excellencies, the co-facilitators of the HLM, Excellency, the Executive Director of UNAIDS, ladies and gentlemen. I am Prasad Rao. I am your moderator for the first panel. To briefly introduce myself, I am a former member of the civil services in India, and I led the national response to AIDS in India during the early years of the new millennium. As Permanent Secretary in Health Ministry, Government of India, I led the first national AIDS control policy in India. I moved to Bangkok to head the regional support team of UNAIDS for Asia Pacific. I was later appointed as the special envoy of the UN Secretary General on AIDS and participated in high-level advocacy leading to the SDG Summit in 2015 and the high-level meeting on AIDS in 2016. I am closely associated with some of the civil society organizations in India working on AIDS and social support among key populations. I am also a member of the National Task Force on COVID-19 to advise the Government of India on addressing key gaps in COVID response. This panel will be addressing the most burning issue of AIDS response, the failure to meet the SDG targets for 2020, prominently on prevention of new infections among key populations, adults and children, and vertical transmission. New infections reduced by a yearly average of only 2% since 2010, which is statistically an insignificant number. The 1.7 million infections that occurred in 2019 are more than 3 times higher than the global target of less than 500,000 new infections in 2020. More than 60% of these new infections occurred among key populations, and the percentage being as high as 98% in Asia Pacific and other regions with concentrated epidemics. A staggering 690,000 AIDS-related deaths occurred in 2019 against the 2020 target of reducing mortality to less than 500,000. HIV knowledge among young people has not increased to desired level, and an entire new generation has grown up without any knowledge of HIV and AIDS, which is an ominous sign. Elimination of vertical transmission has been slow and sluggish, and only a limited number of countries could reach the elimination target by 2020. In short, in 6 years after the countries have set up the goal of ending AIDS by 2030, the global targets set for 2020 have all been missed. Lack of political will and dismantling of the governance structures and delivery systems built during the first decade of the new millennium are largely responsible for this collective failure. And the COVID-19 epidemic has dealt a serious blow to even the limited efforts of the countries to contain HIV/AIDS. The impact of the COVID-19 pandemic on the HIV response is expected to result in almost 200,000 additional HIV infections and about 100,000 additional AIDS-related deaths globally. To address this serious failure to achieve the key prevention targets, we have a panel of experts who are known activists and who did some outstanding work in projecting the gaps and shortcomings in the global response. I will be inviting them after a brief introduction of each of them to make their interventions in 3 minutes' time on the issues posed to them. We will then have a recorded video interventions of 2 minutes from another group of speakers. In between, we'll have time for taking questions from the audience on key issues which need greater focus, subject to time constraints. I would request all the speakers to kindly stick to keep their interventions to the allotted time to avoid audio failure. Now, the first speaker on my list is Julian Bogos Karbogosan. I would like to briefly introduce him. Julian from Beirut, Lebanon, is a global youth advocate with a focus on HIV/AIDS, gender and sexual reproductive health and rights. Board member at Impact Global, vice chairman at GNP Plus, founder and member of MENA Plus, coordinator at Adolescent HIV Treatment Coalition. Julian would be speaking on the progress achieved and challenges ahead in securing equitable and equal access to HIV prevention, treatment, and services for young people if we have to achieve the goal of reaching the 2025 targets. Over to you, Julian.
Today, a new opportunity presents itself for the world to come together to ending AIDS. During a time when the world is burdened by COVID-19, where weaknesses in our systems were exposed, and inequalities further expanded the gaps between us, our vulnerable populations became more vulnerable and marginalized. But with political will, research, and the funding, a vaccine for COVID-19 became available within months with the fastest approval rate and planned rollout. We ask that more resources be available for HIV/AIDS, especially for research around cure, HIV vaccination, and long-acting ARVs. We, the people living with and affected by HIV in Middle East, North Africa, we, the key populations, men who have sex with men, transgender women and men, LGBTIQ+ communities, sex workers, people who use drugs, adolescent and young people, women and girls in all our diversities, refugees, migrants and mobile populations, people in prison, closed settings, and their partners in MENA. We, the civil society, activists, advocacy groups, professional groups, NGOs, coalitions, regional networks, community leaders in MENA. We present this statement with what we believe is imperative to ensure a fair and equitable HIV/AIDS response within the new political declaration. We're not vulnerable or marginalized. We're not numbers or statistics. We are people. Plan and engage with us on the basis of human rights. state all the key populations by their denominations in the declaration, so that we're not only recognized, but also addressed and protected. Repeal laws that criminalize HIV non-disclosure, exposure, transmission, consensual same-sex behavior, gender expression, drug use and possession, and sex work. Address the needs of senior key populations and their well-being. Address inequalities in service provision and programs, including and not limited to HIV and STI testing, treatment, sexual reproductive health and rights, TB services, comorbidities and opportunistic diseases, harm reduction and drug dependency programs, hormone replacement therapy, mental health, and other life-saving programs. Encourage local and regional ARV manufacturing by ensuring access to treatment intellectual properties. Scale up access and adherence to treatment for communities. Ensure that treatment is at the heart of the humanitarian response in countries torn by war and conflict. End stockouts, which increase the risk of developing AIDS and resistance. Address stigma, discrimination, and inequalities in healthcare system, service delivery, at workplace, in financial, legal, and public institutions. Address travel and work restrictions. Support the implementation of UHC to ensure no new infections among newborns. Remove barriers to services for youth. Specific consent for prevention, education, and SRHR. Address the issues of gender-based violence, highlighting the interlinkage of GBV and HIV, access to services including protection, socioeconomic programs, support and empowerment for young women and girls. Scale up innovative prevention programs with focus on HIV self-test, community testing, PEP and PrEP, male and female condoms, as well as access to counseling and awareness programs, especially for key populations. Ensure people with HIV are prioritized in COVID-19 vaccinations and that HIV services are not deprioritized. Pandemic preparedness should ensure HIV services continue and health systems will respond to both pandemic and epidemic. Support people living with HIV and community leadership by ensuring PLHIV are at the heart of the response, decision-making and leadership. Nothing for us without us. Thank you.
I think that was a very comprehensive presentation you made. I now turn to the second speaker, Khuli Buthelezi from Sisonke. Khuli Buthelezi is a feminist activist and founding member of Sisonke, a national movement for sex workers in South Africa of all diversities in 2003. She thrives on the mobilization for safeguarding the health, human and justice rights of sex workers, reiterating the call for the decriminalization of sex work, together with the Sex Workers Education Advocacy Task Force. She wears numerous hats from Sisonke National Coordinator, ASWA Board Member, NSWP and CCM member. She would be focusing on the key populations and problems relating to their equitable and equal access to HIV prevention, treatment and services. Over to you, Khuli.
Delegates, distinguished participants, key populations, good afternoon South African time and good morning from other countries. I hope my speech will contribute to the great value on behalf of the key population worldwide. As women in South Africa, we face a disruptive of the HIV with adolescents and young women and girls aged 15 to 24, and who are most vulnerable with the HIV prevalence. That is 3.3 times greater than the male peers, and also additional key population in South Africa continue to face the highest privilege, HIV and gender-based violence. Key population face criminalization. In South Africa, sex work and people who use drugs are criminal and also punishable with the fine or jail term. Criminalization fuels stigma and discrimination, as well as human rights abuses, increases the vulnerability to HIV, TB, STIs, and hepatitis. The National Strategic Plan of South Africa for the HIV and TB and STI 27 and 2020 of South Africa acknowledge and recognize that despite of the South Africa and recognizes that South Africa being recognized globally and also positioning and response of the HIV, numerous challenges remains, as it is across the worldwide, and also key population in Southern Eastern Africa often face criminalization and often greatest burden of the HIV. South Africa has also developed a human rights plan and gender plan that aims to reduce and discriminate against the key population to ensure that equal enjoyment of the human rights are actually accessible. And also it has the 7 pillars. That is the plan for all key population in South Africa. And South Africa is an international funded combination prevention and programs for key population that are rights-based and also evidence-informed and community-owned. All key population received biomedical and behavioral and structural interventions, which are prioritized to meet the needs of the individuals and the communities to have greatest impact. While prevention and programs amongst the population are increasing, they are still not sufficient scale and also quality to make the necessity impact to reduce the human rights and HIV rights abuse and also the key population in South Africa. The challenges remain across the KPs, communities, and also especially within the rural areas. Also, South Africa is a larger reliant on the international funding for key population programs. Also, for this support, we are very grateful and also ask the continuation of support for these programs that do valuable work in reaching the key population. This program also are built to expertise of the local and the civil society organizations and key populations movement in South Africa, which is vital for sustainability and letting the key populations led. We have a long, long way to go, but we still have a long road to travel where the key populations are decriminalized and no longer face the stigma and discrimination, but working together. We believe as a population that together we will make a difference in our countries. I thank you.
Alvaro Bermejo from IPPF. Dr. Alvaro Bermejo is the Director General of IPPF. He has worked for more than 20 years as a senior executive in global federations, working across HIV and AIDS, humanitarian issues, and health policy. He was previously director at CIFF, where he helped build an adolescent sexual and reproductive health portfolio, in addition to the more established health, nutrition, and educational portfolio. Prior to joining CIFF, he led the International HIV/AIDS Alliance for more than a decade. Alvaro, you have the floor.
Thank you, Prasada. Excellencies, distinguished delegates. I have spent over 2 decades working on HIV and on sexual and reproductive health and rights. While we have made significant progress, I feel part of a collective failure. A collective failure to ensure that adolescent girls and young women in all their diversity, the LGBTQI and other key populations, can access quality, integrated services that respond to their rights and health needs. This remains an important challenge, in part due to the lack of a person-centered, human rights-based approach to health programming, despite integration being promoted as a priority area for some time. Addressing gaps to achieving an integrated response must really become our priority now. Each week, more than 4,500 adolescent girls and young women become HIV positive across sub-Saharan Africa. The integration of SRHR services is more urgent than ever. We urgently need additional investments on HIV prevention, on improved information and counseling at basic sexual and reproductive health services, STI testing and treatment, contraception, pre-exposure prophylaxis, post-exposure prophylaxis, HPV screening, HIV testing, safe abortion, fertility treatment, hormonal treatment, cervical cancer treatment, and ARVs must become fully accessible through SRHR platforms. SRH platforms are also good entry points to deal with the gender-based violence that continues to fuel the HIV epidemics. Testing, screening, and counseling for STIs and HIV constitute important entry points to address sexual and gender-based violence. Let's also remember that despite the majority of the 3.5 million women who inject drugs globally being of reproductive age, their gender-specific needs are largely overlooked. These women have limited access to prevention and treatment and to other essential health services, such as antenatal care. Only a person-centered, human rights-based approach will be able to integrate responses for HIV co-infections, such as tuberculosis and viral hepatitis. Implementation lessons and IPPF's own experience across its 50,000 clinics and delivery points show that non-integrated approaches result in greater loss to follow-up and in missed opportunities for diagnosis and treatment uptake. It is our collective responsibility to continue fostering bold leadership. Leaders who have the courage to see the individual as a whole and meet them where they are with an integrated package of services. This is more urgent than ever as the world faces new challenges and health budgets are under strain to deal with the impact of colliding epidemics. Thank you, Priscilla.
Thank you. Thank you. At a very short time, you have been able to bring the entire gamut of issues to the fore. Thank you so much, Alvaro. I now give the floor to Dr. Judith Kose, Elizabeth Glaser Pediatric Foundation. Judith Kose, I think, sorry, I mispronounced your name. Dr. Judith Kose Oteno is the Associate Director, Pediatric Services for the Elizabeth Glaser Pediatric Foundation. She provides strategic direction to EGPAF for improving pediatric HIV services, including TB and other comorbidities. Judith is a specialist in pediatric infections, disease with over 17 years experience, extending to public health, HIV and TB treatment, execution of clinical programs, implementation research. Over the years, she has supported different country programs, including in the development of guidelines and national training curricula for healthcare workers, and has an advisory role in several global platforms. Judith was the recipient of the 2006 International Research Health Award from the American Pediatric Association. She is a PhD candidate at Erasmus MC in Rotterdam in the Department of Neurosciences. Her focus is on pediatric and adolescent HIV treatment outcomes. Judith, you have the floor.
Thank you, Chair, and greetings, everyone. One of the glaring inequities in the HIV response is the failure to meet the needs of children living with or at risk of HIV. Although children accounted for 5% of people living with HIV in 2019, they represented 14% of all AIDS-related deaths. Only 53% of children living with HIV accessed ARV treatment, with only 37% of them being virally suppressed. My almost 20 years of experience working to help mothers and their children tells me that an AIDS-free generation is possible. It is achievable with renewed political leadership and investment in strategic, patient-centered interventions. I want to highlight 4 main areas that need strong political commitment. First, despite high PMTCT coverage across countries, new infections in children persist, especially during breastfeeding. We must urgently intensify primary prevention efforts for pregnant and breastfeeding women, including pre-exposure prophylaxis and other new prevention technologies. Pregnant women need repeat testing and immediate ART if tested positive. There is also a need for differentiated services for young mothers because 43% of new infections among pregnant and breastfeeding women occur among adolescent girls and young women. Second, we must improve case finding, including strengthened family-centered index testing to quickly identify children with HIV. Evidence has shown that adoption and integration of point-of-care diagnostic technologies can help close the testing gaps, but these have yet to be brought to scale. Children must receive their test results as soon as possible with immediate optimal treatment. In this regard, we propose 2 additional targets. At least 95% of infants tested for HIV receive their test results no later than 15 days after sample collection, and at least 95% of infants diagnosed with HIV initiate ART no later than 15 days after receiving test results. Third, we must address service delivery and innovation inequities around children. There are significant disparities in treatment coverage across regions, and without treatment, 1 in every 2 babies with HIV will die before their second birthday. The development and rapid transition to better pediatric formulations will help reduce the nearly 100,000 preventable pediatric AIDS-related deaths. Fourth, we must put greater emphasis on viral load suppression in maternal and pediatric patients to improve their quality of life and reduce vertical transmission. This means scaling up effective models such as the point-of-care viral load for these priority populations. Ending pediatric AIDS is possible. It is within our reach, and the next 5 years will be critical. To capitalize on this moment, we call for a consultative process to develop a framework to end AIDS in children, building on the success of the global plan and the Start Free, Stay Free, AIDS Free framework. Thank you.
Thank you. Thank you very much. I think absolutely important issues on the PMTCT, and thank you very much for that. The last speaker on my list is Mariam Abubakrin, former chairperson of the UN Permanent Forum on Indigenous Issues and the leader of the International Indigenous Working Group on HIV and AIDS. Mariam, one sec, is chairwoman of the Tinhenan Canada Association. Did I pronounce it correctly? And member of Tinhanen Sahel Association, leader of the Indigenous Peoples International Working Group on HIV/AIDS, honorary member of the Inter-University Center for Indigenous Studies and Research, independent consultant on Indigenous issues. Very important area. Please go ahead. Thank you very much.
Thank you, Dr. Prasada. Excellency, Mr. Volkan Bozkır, President of General Assembly, pendant la 75.
During the 75th session, Excellency Mr. Neville Getz, Permanent Representative of Namibia to the United Nations, co-facilitator for the preparations for the high-level 2021 meeting on HIV/AIDS, Madam Winnie Byanyima, Executive Director, UN AIDS. Taglasam, which is a greeting in my own language, Tamashek, good morning. Allow me, first of all, to recognize the ancestral indigenous territory of Algonquin Anishaba, from where I'm addressing you today, but also the territory of the Onondaga, where the headquarters of the UN is located. Thank you for this voice given to indigenous peoples at this high-level hearing with a view to preparing the HIV/AIDS meeting in 2021 in June. I have a particular thought for all those indigenous people who are suffering in the third wave of the COVID-19 pandemic. What are the health conditions for indigenous peoples? We represent 470 to 500 million people, according to the UNDP. distributed amongst 90 countries, grouped into 7 socio-cultural regions that are very diverse. Although the majority of them are very close to nature and contribute to biodiversity, some are also located in urban centers, but always have a spiritual link with their land and their territory, whether it be on their land or outside that in an urban setting. The dominant health systems in their countries have not been able to provide them with health services, even basic health services at the national level. For example, in Canada, whilst Indigenous people represent only 4.9% of the population, they account for 14% of all new HIV infections. That's a figure from Public Health Canada 2018. The situation is no better with regard to access for sexual and reproductive health. Thus, for the Indigenous women in Namibia, the average percentage of women who have not received prenatal care is 10 times higher than women who are not indigenous. That's a UNFPA figure. Also in Mali, the rules which state that you must be located within 15 kilometers and be a population center of 5,000 to 15,000 inhabitants in order to access a community health center is far from being achieved for the Kel Tamashek people, the Tuareg, which are a nomadic population living in an area with an average population density of 0.45 inhabitants per square kilometre. Unfortunately, the obstacles that the Indigenous people face on a daily basis means that they are not able to enjoy good health. Very much of this is linked to colonization, former colonization. They continue to suffer from stigmatization, conflicts, dispossession, and the militarization of indigenous lands, growing insecurity, a lack of understanding, and a negligence with regard to the histories, indigenous histories, and their unequaled potential to address these issues themselves, such as health issues, lack of knowledge of languages and cultures, and the holistic approach to health that play a central role for us. But ladies and gentlemen, allow me to welcome certain progress that has been made by Indigenous peoples themselves in resolving their health problems. I think here of champion organizations in the area of AIDS, for example, such as the International Working Group on working on AIDS, as well as UNAIDS PCC, and of course through this advisory group, which is preparing the high-level summit in 2021, and other organizations as well, such as the ILO, and others, extending a hand to Indigenous peoples to help them with their help, as well as certain health, as well as certain member states, such as Canada's Indigenous Services, where it's in the form of a ministry providing a remarkable response to COVID-19. Before concluding, in order to win the battle and leave no one behind, including Indigenous peoples, as stated in SDG 3.3, and to achieve a 90-90-90 target for treatment, I would suggest the following: include Indigenous peoples in the preparation of all health programs and policies, particularly prevention and healthcare for HIV/AIDS, as well as tuberculosis and other sexually transmittable and blood-borne diseases. To give an epidemiological breakdown with regard to HIV/AIDS and follow-up, and to adopt with regard to data collection a culturally appropriate approach that's acceptable and with free prior informed consent of Indigenous communities, as stated in the United Nations Declaration on Indigenous Peoples and also ILO Convention 169, and with the leadership of Indigenous peoples, to base ourselves on specific solutions to the context of each people, particularly their rites of passage, and to allocate sufficient funds for health promotion initiatives led by Indigenous peoples, in particular in the area of prevention and treatment of HIV/AIDS and co-infections such as tuberculosis. Thank you very much.
Thank you very much. Yeah, we now move to the second stage of our conversation with some recorded video interviews from various regions, amplifying some of the critical issues raised by our speakers. The first video will be from Karen Dunaway. She is the International Community of Women Living with HIV. I would now request for the video to be played. Video, please.
My name is Karen Dunaway, and I am a member of the International Community of Women Living with HIV. In order to have equitable and equal access to HIV prevention, treatment, and services for young people, it is necessary to have specific indicators in care protocols, as well as special indicators for monitoring and evaluating of young women with HIV. This will not be possible without the necessary evidence and disaggregated data, because it is the main barrier to advocacy and affirmative action. We need to talk to policymakers and no longer among ourselves who are convinced that this is necessary. Youth advocacy agendas and actions should be directed and oriented towards access to services and reduction of stigma and discrimination. Disaggregated information is a key element for decision making. It is imperative to understand that the creation of evidence is fundamental and to commit to maintaining an updated database that allows for timely action. Problems cannot be solved without planning, but planning cannot be done without information. And this cannot be achieved if it is not considered a priority issue to inform decision making. In addition, governments must comply with international treaties or conventions for the promotion and protection of services for young people with HIV. Thus, not only ensuring that the 90-90-90 targets are met, but also reducing stigma and discrimination.
The next video is from Marina Sabayang of the Indonesia PLHIV network. Marina Sabayang has experience in HIV and TB issues for more than 15 years. Since engaged with HIV issues in 2004, she has robust commitment and focus on HIV and TB responses in Indonesia. With her strong education background in Bachelor of Law and Master of Public Health, she also put up effort on her work to reduce stigma and discrimination experienced by PLHIV and people with TB. Marina is also the chair of the Jaringan Indonesia Positive, that is the Positive Network of Indonesia. Over to you, Marina.
The high-level meeting this year is held at a historic time, 40 years after the first reported case of AIDS. While it is clear that we have come far, compared to 40 years ago, we are not done demanding for equitable and equal access to HIV services, because the reality is that the HIV response is not yet meeting the needs of all people living with HIV and also key populations. To ensure that key population needs are met and the global targets are achieved, the world must prioritize actions to benefit key populations. We need combination HIV prevention package that are tailored to the needs of key populations. Unfortunately, even the most basic prevention tools like condoms are not yet available for all. In settings with high conservatism like Indonesia, condoms are mostly provided for married couples, setting aside the needs of key populations and also young key populations. And while PrEP is already available in many countries, Indonesia is only at the early stage of making it accessible. The COVID-19 pandemic has shown how quickly the world can move to develop and distribute vaccines. We can and must do the same for HIV. As I mentioned earlier, we have come far in the past years in scaling up HIV testing and also treatment services. People living with HIV must be able to access ARV medication that is safe and comfortable with a drug regimen that is non-toxic and recommended by the WHO. In a pandemic setting, the provision of multi-month dispensing of antiretroviral treatment was more important than ever, not only to ensure attention but also keep people living with HIV safe. The data shows that 26 million people are on antiretroviral treatment, out of 38 million people living with HIV globally. We simply cannot forget the remaining 12 million people. Thank you.
Thank you very much, Marina. The third and last video we have is from Amaranta Gomez Regalado. She is from Muxje, Zapotec, from the Isthmus of Tehuantepec, Mexico. She is an anthropologist and activist and co-chair of the International Working Group on Indigenous People and HIV. Over to you.
Good morning. I'm Amaranta Gomez. I'm a Mexican indigenous woman and I'm an activist on HIV. Over 20 years, we've been seeing in our indigenous populations that the United Nations, its agencies and member states have looked at us and they have put us on the periphery of decisions. We don't want that to continue to happen. We want to get to the heart of everything. We want to be at the heart of decision making so that this epidemic stops and has a solution. We really need to be allies with the United Nations, their agencies, and states and governments. We need strategic alliances with a lot of trust to generate epidemiological data that is broken down appropriately so that we know how HIV is affecting our indigenous populations. And this is what the governments of the member states of the UN should do. We recognize that there are health programs. What we need, however, is quick tests and appropriate medications so that indigenous peoples can have quick access to healthcare. We need there to be prevention strategies that are culturally relevant. All of that for indigenous peoples, and that would be the best thing that could be done. Thank you.
Thank you very much for that very short video presentation. We will now move into the question and answer session. We have some questions from the floor. I'll be directing them to the panelists. Some of them are directed at a particular panelist, and some of them are general, anyone can take it. But the first question is to Alvaro. According to you, which is the most difficult barrier to ensure SRH HIV integration, reviewing which will make it possible to get comprehensive services for women, girls, and men? Alvaro, you have the floor.
Thank you, Prasada. I don't think it's possible to identify just one silver bullet. I would highlight maybe three very quickly, one at each level. At the global level, I would say the verticality of funding and deadly gag rules imposed by governments who are intent on controlling women's bodies presents a major obstacle. At national policy level, I think we need much better dialogue between HIV and SRHR programs. And finally, at the services level, we need to organize services less around the convenience of providers and more as a person-centered approach around the needs of meeting individuals where they are. I really think those three barriers, as well as a joint commodities supply chain, will make a big difference around the world.
Thank you. Thank you. And of course, a small supplementary from me. We are saying integration on one side. 20 years back, we said AIDS exceptionalism. Are we not erring on the extremes? Do you think the middle path is possible? Just one line.
Yes, I agree with you. I prefer to talk about maximizing or optimizing the use of family planning platforms for HIV services. I think that's the way we need to approach it. But I'd agree with you. I think somewhere in the middle is the answer.
Thank you. Thank you, Oliver. Okay, my next question is to Julian from the floor. Very direct question. After 40 years of HIV, are key populations still left out of so many government responses? Why? It's a big question, I think, on the minds of everyone.
Yes, definitely. I think it's definitely a big question, and definitely, yes, they are still left behind. And as well, they're more left behind in some regions rather than in other regions, depending also on the laws and policies and the countries at the local level. So I would say that yes, they're still left behind, and even sometimes in the well-developed countries, they are as well left behind. I would say that for us to be able to get more inclusive engagement, and also for integration of services. When we talk about integration of services in countries where there is criminalization of key populations, there is a question on how that is possible for integration of services as well. So I think the way forward is definitely to decriminalize all ways and forms of the key populations. Thank you.
Thank you. There's one question to all the panelists. Anybody can take it. What will they suggest will take to realize a person-centered and human rights approach to guarantee health for all? Very difficult question. And anyone can start. Maybe those who have not answered can take the floor. Or I can ask someone specifically. Yes.
Thank you, Prasada, for that very interesting question. And I agree with you, it's a difficult one. But I think to achieve the, what you talked about, human-centered and human rights services, one of the key things that we must have, it must have human-centered design. So if you're developing anything for adolescents, for key populations, for indigenous people, they must be involved in the design of those services. And on top of that, there's a need to identify their various needs, their various unique needs, to include it in the model, while also integrating the data reporting and occasionally coming back. So this process needs to be iterative, so that you keep coming back to review what works, what doesn't work, and keep improving it. But I think the center of it is involving the key people who we want to reach.
Thank you. Anyone else would like to take that question? Okay. Otherwise, we have heard the video presentations. Marina from Indonesia mentioned specifically about the problem in Asia Pacific. 98% of the new infections in Asia Pacific occur among key populations. This is a challenge and also an opportunity. How do we look at it? And what is the best way to motivate the governments to invest judiciously in preventing new infections among HIV, among key populations? Anyone can take the question. Maybe Alvaro, you have more experience about Asia. Yes, please, go ahead.
Yeah. I would like to respond to the question that was asked around the human-centered and human rights. In addition, I think the importance of the inclusive of the key population in any craft of any plan or any, as we're talking about the ending HIV 2030, I mean to say, so it is important that we include and the key affected people in implementation and also in polishing all the plan and also policies that we put in place in terms of ending the HIV, but also specifically for the key community that is criminalized. I strongly believe myself that the decriminalization of sex work, it will be able to enable all the implementation and also making sure that the human rights of the key population, it is recognized. Thank you.
Thank you. And the question on Asia Pacific, anyone would like to take?
Yes, since you prompted me, Prasada, but I'd respond along the same lines as we've just heard. I think ultimately we need decriminalization to really be able to respond properly. Having said that, I would also agree, and we've seen lots of examples in many places, that even with criminalization, there's a lot more that can be done than what we're doing now. So we really need to involve them in the design of solutions and in the provision of services, not just as clients of services that they contribute to design, but community organizations of key populations as providers of services. We need to make much better use of their own capacity and see them as part of the solution, not as part of the problem.
Thank you. Thank you. There's one question which has come, of course, which deals with COVID. The end of HIV/AIDS is possible. The impact of COVID-19 is rolling back gains. What needs to happen at HLM to keep the momentum?
I think that's a very good, important question at the same time. Yes, I think that's a very good and important question at the same time. You know, as I have said in my talk earlier today, we have seen that within months with the government's political will and with the investment and funding, vaccine was planned and it was approved and rolled out quite much fastly all over the world. I think that's what we need right now. If this is happening with COVID-19, why it cannot be happen for HIV? A question to be asked. We've been fighting this epidemic for the past 40 years and we are still suffering, and treatment access is still an issue and all the points that I have discussed during my talk. Why are we still here today? That's the question which also would possibly like to raise. Again, I think it's important to be always engaging with all the key populations. We know that also youth are main key component of leading the HIV/AIDS response. And here I would like to refer also on the Global Youth Statement, which has been prepared by all over the youth networks all over the world. It's important to have a look on what young people are saying today. Thank you.
Thank you. I think Kose want to come in. Kose, you have the floor.
So thanks. So I think you ask a very interesting question, and indeed it's true that COVID came. It has eroded a lot of work that had been achieved in the HIV sphere. But I think I want to look at it from the other end. The other thing that COVID has done, it has brought out the innovative side of people. And so in the last year or so, there's been a lot of programs that have developed innovative things such as virtual care, and other ways of looking after people with HIV. So I think in the HLM, it would be great to harvest some of these beneficial interventions that we have developed because of COVID, find a way to scale them up and to continue with them. And in scaling them up, perhaps include other key populations, children, adolescent girls, and young women that may have been left out in these innovations. So yes, COVID has had a negative effect, but I think we are also seeing some benefit and some positive effect from the innovation side. Thank you.
Thank you. Thank you, Kose. Now that you have brought the innovation issue, I have one question on innovations. In the last 10 years, many new technological innovations have been brought to strengthen the AIDS response. PrEP has come, HIV self-testing, introduction of DTG have all been successfully piloted. But many countries haven't been able to scale up the desired levels in their national responses. We're still doing pilots and pilots and pilots. How long these pilots will go? What can be the reason for this lack of commitment to scale it up to the level where they can make an impact? Any one of you.
Thank you, and sorry for coming back in on that great provocation and question. And I think it's a very important one for the high-level meeting. I would argue part of the reason is because we're not using the existing platforms that we have to introduce these new technologies into the healthcare system. This was precisely my point around sexual and reproductive health platforms. So we see that in many countries, adolescent girls and young women are coming to get their contraception, and a year later are returning with an HIV infection. And in between, they have got access to no prevention technologies, no intervention. Even though we have PrEP, they don't know about it. They haven't been offered it. We have dual prevention methods, none of that. They haven't even, in many cases, got appropriate counseling or any ARV based prevention. So we need to make much better use of existing platforms and better plan the introduction of these new technologies through them. It won't just happen by the HIV community thinking on its own and planning on its own. We need to use the mainstream health system.
Thank you. Thank you, Alvaro. Next, Julian also wants to come in. Julian, you have the
floor. Yes. I would say definitely, I mean, I would summarize it in 2 words, political will. That's how I will answer this question, because after all, okay, we know these kind of prevention technologies are available. Sometimes the communities are aware of them and they are well informed. Sometimes they're not. Civil societies are playing a big role in this part to ensuring that everyone who needs access to those prevention, they're trying their best. But again, political will in rolling out, political will in awareness around the availability of these prevention tools, how they work, how they are used, etc. That's how I will answer that. Thank you.
Thank you. Dr. Kose, please come in.
Thank you. I think just to add to political will, I think the other challenge that we see in terms of, countries not scaling up innovations like HIV self-testing or DTG is really available supply. And this has to do with political will, but also funding for it. So if HIV self-testing has been proved to increase access to testing for men, a country may have it in their HIV testing guidelines, but there's a question of who is going to fund this, for it to be available and to be rolled out. And this is linked very closely to political will, because if the political will is there, then there'll be funding, domestic funding for it. But most of the time you find that the funding is not domestic, and this can affect scale up. Thank you.
Thank you. We all heard about social contracting, funds coming directly to communities for implementing programs. How many of those social contracting systems now exist? They were very much successful in the first decade of the new millennium in bringing down the infection levels. We don't see it much nowadays. What has gone wrong? Why the social contracting has failed? Because the governments have lost confidence in the communities that they can implement programs well? What could be the reason? Can anyone hazard a guess? Alvaro.
We've seen it be very successful, particularly in industrialist countries in the early stages of the epidemic. And then as we've tried to build these systems in emerging economies, they have not come together. I think it's 2 things. One is or 3 things. The lack of political will. Governments in many places do not trust community organizations. And of course, if we're talking about criminalized communities, that's even more difficult. Number 2, it's the own weakness of if you want, state bureaucracies in order to be able to go ahead with those contracting in many places. So political will, trust, and an established civil service or government bureaucracy that can do that. I think those 3 are the same, the key issues. But we've seen where it's happened, and we've used in the Global Prevention Coalition examples of Mexico and many other places which have been very successful to try and promote that. And I think there's a lot to learn from the countries that have been successful. India being one, by the way, which you know well.
Thank you. Dr. Kose.
Dr. Kose, yeah. You can hear me?
Yeah,
I think the other challenge why these service contracts, the community contracts, are no longer in place, perhaps is because there was no plan for sustainability. So when these contracts are started, there is funding for it, it's being implemented, but at the beginning there needs to be a sustainability plan so that when active funding is no longer there, then the community structures can carry this along, especially the positive elements. Thank you.
Yeah, that's true. That's true. And the sustainability was an important part there. One question that troubles me is regarding awareness among general population. As I mentioned in the beginning, an entire new generation has come up in the last 15, 20 years without any knowledge of HIV. There is no sex education anywhere, except maybe some few exceptions. Why is it that the basic awareness programs like sex education are not part of national priorities? Are youth not important for country leadership? Don't we want our youth to be well aware of the risks of unprotected sex? What has gone wrong? Julian, Alvaro, Julian next.
Yes, I think that's a very important, good question as well. And awareness is very important. True information is available outside schools as well on different platforms online. But then again, when we're talking about education, we're talking about children and young people who are at school. What about others who are not out, who are out of school? What about other young people who are in war settings, who are in conflict zones, who are in conflict areas? That's a big question. Again, when we talk about education, we go back to school systems, we go back to Ministry of Education. So political will, that would be my answer. Because in some countries also the cultural barriers and the religions and those kind of things stand against that to happen at schools. Thank you.
Okay, thank you. Any other speaker would like to take the floor on this?
Thank you, Prasada. This is a question that goes to the heart of the work that IPPF does as a large provider of comprehensive sexuality education around the world. And I'd very much agree with what Julian has said in terms of political will. And we need to be aware that we are facing an opposition, a conservative opposition, a populist opposition that is opposing comprehensive sexuality education, and that is better organized, better financed, and more aggressive than it has ever been. So the backlash, in a way, and the pushback is not just because of it being a new generation, but also because in many countries, societies have become more conservative and the political will is not there anymore. So we need to continue advocating very strongly and making it clear that ignorance does not protect. It is knowledge that protects, and it is by helping young people understand the world around them and their life skills and possibilities that they have that we will protect them, not by keeping them in ignorance. I think that has to be the key message.
Thank you. Can I ask Dr. Kose to come in now?
Because the other thing I'm going to add is, you know, for us to manage to create awareness among the younger generation or next gen or generation Y, whatever you call them, I think the policymakers and people who are making these decisions at table should either include these young people or be responsive to their needs. So very often you find that the policymakers are in their 50s, are people who are older, and they're basing certain decisions on what they knew growing up and what they assume the young people need. But I think times are changing. We need to keep changing and be responsive to the young people as they emerge, so that we adapt the ways of creating awareness and information giving to what the young people can match with today and what they resonate with. So for instance, right now, you know, there's a lot of social media, and yet for people like me, I'm not big on social media, but the younger people will perhaps respond more positively to messages through various social media platforms. So I think in short, it's good to involve the people we are targeting when we are making policies, and even perhaps bring them to the table when some of these issues are being discussed.
Thank you. Dr. Abu Bakrin, first time you are taking the floor. Welcome, please.
Merci beaucoup.
Thank you very much for excellent question. I'd also like to thank the previous speakers who touched on different issues. I'd also like to bring in education more generally for Indigenous peoples. There's still a lot that needs to be done, and it's really important because that's where we can change things. So when we're talking about sex education and prevention of diseases in general, it's really important for this to be included in curricula. But also the communities, indigenous communities need to be involved in the drawing up of these curricula so that the content is culturally adapted. And this also chimes with what is acceptable on the community level and what has already been done. So I'll take a quick example. Someone I met, an indigenous leader, during the Conference on Population in 2019 in Nairobi, Kenya. So it was the ICPD plus 25 conference. Then I met this indigenous leader and I said, what are you doing within your community for prevention of STIs and on sex education more broadly? And he said, well, this is what we're doing. Well, we don't have pre-established programs. What we try to do is we go through rites of passage, and there are dances organized for rites of passage, and then we organize these dances, and that's where we spread our message. And they are co-created and led by the people themselves. So we need to perhaps take as a baseline what exists already in communities and then build on that. Thank you.
We have one question here, which is, I'll just address it to all of you. Yeah, this is for Julian and others. What do you suggest in regard to advancing political will? What steps can we take to hold government accountable to prior commitments to SRHR, rights to health, climate response, indigenous sovereignty? These must be addressed before moving forward. Very difficult question. Political commitment. Julian.
Yes, I think for us to be able to address this political will and to be having that political will, what we need to do is advocacy. And when we say advocacy, advocacy doesn't happen only on the global level and in such kind of meetings that are as well very important. But when we say advocacy, it happens at the local level. We have been, as civil society, getting so much ready for this meeting, as you all know, doing webinars, telling people how they can interact with us, how they can help us, how they can advocate locally by meeting the delegations at the local level, sending them the statements, all the global statements and the regional statements of what the communities want. This is how we can do it. We know how to end HIV. We know what's needed. Only what we need is simply to push and to get that political will. Thank you.
Thank you. There is one question which is about provider attitude towards the adolescent girls and young women, how it can be best handled. Because that is the main reason why most young people fear seeking health-related services out of fear of discrimination. Very important issue, because sometimes the health system itself can play a role of discriminator. I mean, this we have seen most of us. But any response on that?
Offering services for young people, for adolescents and young people, the services have to be responsive. And I agree, one of the challenges has been the healthcare provider, their attitude sometimes towards an adolescent. For example, if you have an adolescent who wants family planning and she's 20 years, so the attitude sometimes keeps the adolescent away. One of the ways to achieve this really is simply training the healthcare worker to be responsive, and for them to understand what the adolescent thinks, how they think and how they react to things, so that the healthcare provider is responsive. The other way to address this is, to have a facility, once they're trained, we have standards on adolescent responsive services, and to keep checking that those standards are being adhered to and helping them manage where they don't get there. But the other element is to also involve young people to provide services for this adolescent. And again, find a young nurse, a young matron, a young peer educator that can work with them. And this will be somebody who can also give feedback to the healthcare workers on when things are not going well. So a feedback mechanism to be able to listen to the voices of the adolescents in terms of how the services are being provided, so that the facility with the trained staff to be responsive is able to, revise how they're giving services to keep improving. Thank you.
Thank you. Dr. Abu Bakrin?
beaucoup. Donc, pour ajouter.
I don't really have a lot to add to what my previous speakers have said, but it is important to counter stigmatization. We've lost the speaker, unfortunately.
Lost her.
Okay.
Thank you very much. Just to add what the previous speaker said on stigmatization of young people in healthcare services, I want to add that it's not only in healthcare services that young people are stigmatized, and even more broadly, people who are asking for family planning or simply asking for an STI test. So it's across the whole community sometimes, and that there's a risk. And so therefore it's really important to focus on this question. So now, it's vital for these services to be provided by peers, by other young people, so that young people can understand what they're saying and they have a rapport with them. And this comes about through training. So training is really important. And in an indigenous context, it's really important for an intercultural level of training. It's not the same way that we tackle health issues here with an adolescent in our community. It's because if we look at a adolescent with a different background, so it's really important to adapt how we adapt the programs to the context and the target population. Thank you.
We have 3 interventions, Julian, then Kohli, then Alvaro. With that, I think we can finish because we are running now almost approaching time.
Yes.
1 minute.
I would say as well, age of consent policies in many countries are main barrier for young people to be accessing the services. If something is legally not accepted, how do we accept the communities or the societies to be accepting it? Age of consent policies, stigma and discrimination is a major barrier. Again, I would say, look at the statement of the Global Youth Statement, hear from young people, what do they want? Because this statement was written by all the global and regional youth network globally. Something else I would say, definitely it's important for young people to be service providers themselves, as well as when we have those kind of clinics or whatever the service providers are located at, when they are working in very strict hours, when those young people are either at school or at work, how can they be accessing those services when I have to call and ask for an appointment? How far will a young person who is getting an HIV test would do that? If I want to get an HIV test now, I want to get it right now, no matter how, because tomorrow I might change my mind. We know that this is also something which is not easy to be done by young people. Something also I would refer to a short story if I have the time. I'm not sure, but I mean,
I think we need to. We are running short of time now. Yes.
Okay. Thank you.
Yeah. Thank you. Yeah. Quickly from the Dr. Kohli and then Julian. Quickly.
Hear me? Thank you so much. A couple of things that I would like to raise and to bring to the attention of this hearing is that COVID actually has hit hard to the key population. So therefore, I think it is important that if sex work were to be decriminalized in the countries, sex workers would be able to have access to all the benefits, just like any other general communities. Also, the issue of the youth, I think the challenge that we're having is the stigma and discrimination towards the healthy facilities. If we're to have a space where it's free stigma and non-judgmental, the youth and young women and girls, they will be able to access facilities without fear. And also funding, I think around the advocacy is important, because that then will also give an opportunity to organizations and community-led organizations to do the advocacy work around any issues that concerns them. The pilot and also the monitoring of the evaluation of the service services that are put in place, it is important because therefore that gives us an opportunity to be able to see that what we put in place, is it working or it's not working. To have healthy champions, I think, around the young women and girls, and also more awareness, people to understand that education is about the safer sex. It is not about the sexual intercourse, but it is about the safer sex. Lastly, I think my comment would be the big barrier is the criminalization. I see today we're having this hearing, so I'm hoping that as I'm representing the key population, being the key population myself, we plead this platform to recognize the call for the decriminalization and remove the criminalization, because it will then give us an opportunity to have access to all the concerns that we brought forward. Thank you.
Thank you. And I have 3 minutes left, so maybe I will use the time to sort of wind up our discussions and wrap up. I think it has been an excellent and very stimulating discussion we had. I feel a sense of déjà vu because 20 years back, just before the on-gas 2001, we almost had similar interactions. And the same passion, the same commitment, we still see among all of you. And please keep it up. Congratulations. I think to all of the panelists, all the video presenters, you've done a great job. But the real issue is now, from now to New York, what is going to happen? The countries are going to come together to draft a resolution which will be more or less finalized by the time everybody brings it to the HLM. So how can we input into that discussion, that consultation, and the views of the governments, the concerns that we have expressed here in this forum? How can we communicate it to them so that they take notice of it and they put it into the resolution? Not just as a resolution, but as a commitment. So that by 2025, again when we meet, we should not be facing the same problem again, saying that, okay, so many things have not happened, so again the same sort of fault finding. It's not going to happen. So we have really missed many targets for 2020. How can we see that these lessons are learned by everyone, by governments, by civil society, by the UN system, everyone, so that by 2025, we can approach with a lot more optimism, a lot more confidence, and a lot more commitment from the political leadership that, look, we lost an opportunity for 5 years. Let us make it up. Let us see that the response is put back on the rails so that by 2030, we reach that ending AIDS as a public health concern. At least that can be reached. So I think that is the fond wish that all of us have got here. And but let's hope that from now till the HLM, this good work that is being done by all of you can get reflected in the combined political commitment of the countries in the form of a good, strong, and effective political resolution. With those words, I once again thank all the panelists, all the video presenters, and the organizers for organizing this excellent panel one. And thank you very much to everyone. All the best.
sorry, we've been having some technical problems there. Perhaps our moderator has muted her phone. We're now going to go into this panel, and I'm going to introduce our first speaker. Our first speaker is Reverend Christo Grayling. Reverend Grayling is a Senior Director for Church and Faith Partnerships for World Vision. He is co-responsible for the development of the Channels of Hope methodology, which has categorized over 500,000 faith leaders in 48 countries. They've been mobilized to respond holistically to complex societal issues such as HIV stigma, care, child protection, maternal and child health, and gender equality. He served as the co-person for the network of religious leaders infected and affected by HIV. Reverend Christo Grayling, you now have the floor.
I think we should turn off my camera. I don't know if it's causing a distraction.
Good. I see I'm in the wrong video, so let me go here. Excellencies and distinguished delegates, it's a privilege to speak to you today as a person of faith. I speak for World Vision International and the Interfaith Health Platform because we have witnessed the incredible role faith actors have played and will play to get us to zero HIV-related discrimination. We all know that to overcome the barriers of HIV prevention, treatment, and care, we must build bridges of collaboration, reaching out to those who do not always share our ideas and way of working. Those amongst us living with HIV know too well that stigma and discrimination form one of the most significant barriers to HIV. Prevention, testing, treatment, care, and support. It weakens the ability of individuals and communities to protect themselves from HIV and to stay healthy if they are living with HIV. Sadly, faith has often been used as an excuse to stigmatize and discriminate. I know that many of us here today might have faced stigma and discrimination by a faith leader or institution. This is not acceptable. It can and must stop. Faith traditions share the belief in the inherent dignity and value of each human being, dedication to end injustice, and a commitment to care for the most vulnerable and marginalized in society. These principles, together with equipped and empowered faith leaders and faith communities, are essential to address stigma and discrimination and allow us to achieve the HIV outcomes we dream of. We want you to know that several faith groups are working together to create this positive faith in action. Faith leaders, faith-based organizations, and people of faith contribute meaningfully to the various aspects of faith, the HIV response, providing services to the most marginalized, such as irregular migrants, using places of worship to create demand for HIV services, addressing myths and misinformation, preaching sermons to tackle stigma and discrimination, or raising awareness of HIV. Stigma poses particular challenges to many children and adolescents living with HIV around the world. Babies may become HIV positive because their mothers fear judgment and do not seek prevention or vertical transmission services. And parents and caregivers do not bring their children for HIV testing. And many adolescents in boarding schools drop out of treatment to avoid being judged. We also know that discriminatory laws, policies, and practices against people living with HIV are both a consequence and a cause of stigma and discrimination. As faith communities, we believe that stigma, discrimination, unjust and unfair laws, policies, and practices and human rights violations against people living with or vulnerable to HIV threatens to progress to where we want to see. For an effective HIV response, we must address structural and social barriers. It is therefore essential that the political declaration commits to the following three areas. One, urgent measures to eliminate harmful laws, policies, and practices. This includes how we criminalize HIV transmission, travel restrictions, mandatory testing, and measures blocking access to services for key populations. And two, support for multi-stakeholder partnerships, including faith actors. This is essential to understand and address all factors that contribute to the spread of HIV and reinforce social injustices. And third, investment in the interventions to reduce stigma and discrimination, such as the framework for dialogue between religious leaders and networks of people living with HIV, the stigma index, and other promising practices. I believe that faith communities have a moral responsibility to support legal and social environments that advance human rights, gender inequalities, social justice goals, and successful strategies for HIV prevention, testing, treatment, care, and support. And we are already doing so. I invite you all to consider faith-based organizations as one of your key partners. As Archbishop Desmond Tutu said, we are the agents of transformation, capable of turning the tide against the disease. We must recognize our interconnection, regardless of geographical, cultural, or religious constructs. We must respect each other. We must stand shoulder to shoulder, heart to heart in the fight against HIV and AIDS. I thank you.
I do want to begin by apologizing to the most honorable Dr. Emery Brown, who is the Minister of Health, the Minister of Foreign Affairs from Trinidad and Tobago. We violated our protocol by not having the minister speak first. My apologies to you, sir. Minister Brown is also a former ambassador from Trinidad Tobago, the Minister of Social Development, a former two-term parliamentarian with over 15 years of experience in leadership, team management, and government at the national, regional level, as well as in public service and non-governmental organizations in Trinidad and Tobago and in the Caribbean. Minister Brown, you now have the floor.
Thank you very much. It's a pleasure to see you this morning. Executive Director, UNAIDS, Madam Moderator, and I do look forward to hearing from you as well and your voice shortly. Fellow panelists, good morning from beautiful Port of Spain, Trinidad and Tobago. Now, the legislative mechanisms that impact on the susceptibility of key populations to HIV and AIDS are shaped by a range of influences, including the unique cultural characteristics of our various societies. Notwithstanding the differences between countries, the imperative of the law to safeguard the interests of key populations remains unequivocal. It is critically important for all governments to provide an enabling environment for an effective public health response to HIV through the development and enactment of appropriate policy and legislation, which will redound to the benefit of all in society, including our key populations. Crucially important to this is increasing awareness of the compelling public health rationale for legislative reform and eliminating stigma and discrimination. It is essential to educate key populations about their rights and mechanisms to enable reporting and provide redress when rights are indeed abused. A supportive and enabling environment for key populations and vulnerable groups must be promoted by identifying and confronting underlying prejudices and inequalities through community dialogue, advocacy, policy and legislation formulation, and implementation. Another very important mechanism essential for legislative reform to be effective is the implementation of a redress system for reporting of abuses and discrimination against our key populations. In many countries, HIV transmission is fueled by gender norms that support cultural, social, economic, and legal barriers to the realization of human rights. Unequal power dynamics, gaps in educational attainment, and sexual violence exacerbate the risk of sexual transmission of HIV. These inequalities result in gender and sexual minorities having less information about HIV, having fewer resources to take preventative measures, and ultimately diminish their chances to negotiate safer sex and access to treatment. Thus, it is necessary for prevention, treatment, and care interventions to take gender-based risk and vulnerability, including gender-based violence, into account. Legislation must also ensure that all information concerning examinations carried out and an individual's health status is discreet and of a strictly confidential nature. There must also be provisions to ensure that the quality and scope of HIV services available to persons in prisons and other closed settings are similar to that provided to the broader population. Legislation must also protect workers living with HIV and AIDS across the board and key populations from discrimination and wrongful dismissal. The elements of legislative reform that I've referenced are but some of the requirements with respect to key populations. The measures that I've outlined, however, are joined by the common thread of the objective of equitable treatment for all in our societies. I thank you, sir.
Thank you very much for those well-positioned remarks. I wanted to continue and remind everybody that we're in panel 2, the structural and social barriers to achieving HIV outcomes, 0 new infections, 0 HIV-related deaths, and 0 discrimination. The panel deals with scaling up community-led prevention, testing, and treatment, addressing social enablers, youth empowerment, repealing punitive laws and policies, addressing gender inequality, ending gender-based violence, and violence towards key populations. This includes ending stigma, discrimination, addressing disability and migration, strengthening safety and security, including privacy and data security for people living with HIV and key populations. We're now going to proceed with the panelists. I'm now going to introduce Marcela Romero. Marcela Romero, I'm sorry. Marcela Romero is an Argentinian trans feminist activist and human rights advocate for the trans populations in Latin America and the Caribbean. She's the regional coordinator. Do you have your translation on, Marcela? You can indicate that you want to hear us in Spanish.
Sí, en español.
Sorry, are you hearing us in Spanish?
Sí. No escucho la traducción ahora.
Is Marcela available, able to hear in Spanish? I hope we haven't lost Marcela.
Bien, bien.
Are you able to hear now? Okay,
Bien,
thank you.
gracias.
Okay, so I'll continue with my
Pero yo lo
introduction.
escucho en inglés.
Sí, ahora, creo que puedo
Trans
hablar.
activist for human rights and for the trans population.
Él está presentándome en inglés.
He is the president of the Argentinian Association of Transvestites, Transsexuals, and Transgender. She is the president of the Federation of Lesbians, Gays, Bisexuals, and Trans People. In 2009, she received the National Congress, from the National Congress, the Outstanding Woman of the Year Award. Quite an honor. And she was the promoter and author of Gender Identity Law, promulgated in 2021. In 2017, Marcela was founded the Trans House, the first space directed by trans people in Buenos Aires. She is currently the director of this house. You now have the floor.
Sí, buena.
Yes. Good day to all, ladies and gentlemen. I'd like to talk about the topic of discrimination in the trans population. HIV/AIDS comes from the hands of poverty, social exclusion, institutional violence. It comes from gender-based violence and, of course, all violence perpetrated against trans people when we cannot access to health care without discrimination. Governments and states are in violation of all human rights of trans people, especially the right to identity and gender in trans people, to have access to quality services, access to human rights, and access to services where we can access them without a fear of discrimination. Ill treatment and exclusion, which is our experience of trans people in our region, is very strong. It leads to HIV/AIDS rates of 35% in our population, exclusion, hatred, and, as I said, access to services, which are unavailable to us. The right to gender and a right to identity is enshrined in law, should be enshrined in law, and that is the main barrier to trans people not being able to have access to what every other citizen has access to. This should be discussed in Parliament, and the right to identity needs to be discussed. It's a universal right. It's a person who doesn't have a name, who doesn't have an identity, doesn't exist. And for us, for the political agenda of governments and their plans, we just don't exist. So what's necessary is to deepen the HIV agenda in our region. In a time of a pandemic, the COVID pandemic stripped away all the veils that the states have, the lack of resolutions to respect identity of trans people. In those countries where there's a law about gender and identity, there is a decrease in HIV/AIDS rates. We can have access to treatment if we have identity. And in there, we can meet our needs without having to face the violations that what we're asking for from the United Nations and what we're asking for from all governments is first that there be a discussion and enactment of laws whereby trans people can enjoy an inclusive democracy and whereby we can access to all the benefits that all other citizens around the world have access to. And poverty also impacts. 29.9% of trans people live below the threshold of poverty. We die in the hospitals in total exclusion, complete isolation. We do not receive care, quality care, or any respect for our identity. Trans persons have access to health care just a few days or hours even before they die. And the issue of mortality, HIV, AIDS, That's the main cause of death for trans people. The second is hate crimes. And the third cause of death is poverty and forced migration. We trans people say that without human rights, we will not have access to prevention and care and universal treatment. What's needed is to deepen the healthcare agenda in our countries, and it's necessary to create inclusive spaces for trans persons. At this time in our region, the death rate for trans people is between average age is 20 to 24 years of age. We need to talk about sexual exploitation also for trans men and women around the world, and launch campaigns, awareness campaigns that would be effective, that would be launched by trans people. And one of our requests to all governments is that we be included in the political agenda. We need to be included in their political agendas, an agenda of prevention, care, and treatment. In our region, you can't talk about the violence of treatment. The violence inflicted on us is very strong. It's inflicted by the institutions. It's inflicted through complete rejection by healthcare providers and institutions. The violence against us is very strong. So what we need to do is work together to try and create an agenda together, a political agenda whereby we can first and foremost eradicate discrimination against trans people and enact laws that will benefit us and protect us. So we have all the social, economic, political, cultural, and environmental rights that all citizens in the world should enjoy. And we say to the United Nations, it's necessary to deepen this agenda. Trans people are not just a thesis. We are people, citizens, and we need access to all benefits, just as every other citizen accesses those benefits. Thank you very much for allowing me to present, and I hope that we can continue working together to decrease and eliminate discrimination and the damage caused in terms of HIV/AIDS, especially for trans people. Thank you.
Thank you so much, Marcella. I want to apologize because I believe I may have, and I know in the program note, your name was, there was a typo and it said Marcello, and we know you're a woman and that the proper name that you have is Marcella. We're now going to try to turn back to Rita. My apologies for the technical. Rita is to be the moderator of this panel, and please, you have the full floor, Rita. Hopefully we can hear you. Please go ahead.
Sí. Hola.
Hello.
A todos. Gracias, Edith.
Thank you. Thank you, Marcella. Hello. Good day to everyone. Thank you. Thank you for your presentation. The interpreter reports that the sound is cutting in and out, not even getting whole words. The sound is not of a quality as to be able to interpret, reports the interpreter. The English interpretation is suspended momentarily.
Técnicos. No lo he podido hacer.
Hello. Okay, I really must apologize for all the problems that we're having with the technical side of this today. We're now going to hear from Richard Lusumbo. Richard is a Ugandan human rights activist who has worked with the LGBTIQ and sexual reproductive health rights movement for the past 9 years. Richard is also the founder and national coordinator of the Uganda Key Population Consortium. This group brings together all key populations for a unified ground of HIV advocacy, sexual reproductive health, and other community needs. Richard, you now have the floor.
Thank you so much, Eric. Good morning, good afternoon, and good evening. I'd like to thank the organizers for this opportunity to speak about structural barriers. For decades, communities have been leading effective HIV responses and addressing structural barriers. Increasingly, communities in Uganda and elsewhere also play a critical role in identifying gaps within the HIV/AIDS response through community-led monitoring. At Sexual Minorities Uganda, I was involved in pioneering a community-led monitoring tool called Rights Evidence Action, or REACT. Developed by Frontline AIDS, through REACT we're able to record data about human rights violations in our community. We use this to shape our programming, helping us to build new alliances with the legal sector, such as fighting structural barriers through courts. We developed a report, and that's how Survive Being Killed, which shone a light on human rights violations against LGBT people in Uganda. From law enforcement, families, media, health workers, and others. The report provided a firm footing for advocacy to defending rights and to fight the fight for HIV services. Even in the face of anti-gay laws and the rising homophobia, we've got dedicated HIV services for men who have sex with men. The community-led monitoring processes has further shown that we can reach the persons who need life-saving medicines. Treatment literacy remains a considerable gap. This has undermined retention and adherence. This gap was further amplified during the COVID-19 lockdowns, where movement restrictions made it difficult for persons living with HIV to reach facilities. Because of limited treatment literacy, some received the wrong combination as not reached their own. This put their lives at risk and undermined the efforts of ensuring that lives are saved. Thanks to the community-led monitoring, we have made a solid case to our government and PEPFAR that it should fund directly and adequately organizations of people living with HIV to implement ongoing comprehensive high-impact treatment literacy and peer-led support programs to complement the current initiatives. Through time, we have learned that empowered communities are a force of change that can move us to epidemic control, leading to ending AIDS by 2030. This vision can only be carried through if it achieves the goals set by UNAIDS 95-95-95. But as you can learn from my presentation, without hearing from communities about the barriers they face, whether that is homophobia or treatment literacy, will continue to lag on the last 95. This past year, communities have also been the backbone of the COVID-19 response. In this political declaration, I urge governments to recognize community-led responses as central elements of health and care systems, and ambitious political and financial targeted responses, including community monitoring, as well as removing structural barriers. Thank you.
Thank you so much for those kind remarks. I must really apologize to Mirta Ruiz Diaz, who we've lost her connection completely. We'll now move on to the next speaker. It's Kamali Powell. Kamali has a wide range of experience in the nonprofit sector and has spent more than 20 years advocating for social justice, youth, arts, and culture. Prior to starting the Rainbow Railroad, which he runs in Canada. He held numerous director level positions at the organization and in other organizations, including the HIV Legal Network and the YMCA. Kamali holds an undergraduate degree in political science at the University of Ottawa. He holds a Doctor's of Law degree from the University of Victoria. Amongst career highlights, Kamali helped launch the Canadian HIV/AIDS Legal Network, and since which actually helped to challenge Jamaica's anti-sodomy laws and developed a monitoring and evaluation framework on legal advocacy. Since joining Rainbow Railroad as its executive director, he has led the organization through transformational growth, which has resulted in successful interventions in multiple countries. Kamali and the Rainbow Railroad have been recognized with several awards, and Kamali has been listed in Out Magazine's Out profile of 100 influential people in the LGBT community. Kamali, you now have the floor.
Thank you. I'm grateful for the opportunity today to talk about community leadership and addressing human rights barriers that impede HIV outcomes. Persecution related to sexual orientation, gender identity and expression, or sex characteristics is pervasive globally. Approximately 70 countries have laws on the books that criminalize same-sex intimacy, with several imposing the death penalty. These laws, which are often a legacy of colonization, are powerful tools of repression and extortion. Homophobic, biphobic, and transphobic violence in families and social networks forces people to conceal their sexuality or gender identity, or physically hide themselves away out of fear. Where countries actively promote persecution of LGBTQI persons, people face unimaginable human rights violations, including killings, torture, arbitrary detention, and widespread discrimination in access to healthcare, education, employment, and housing. And in recent years, we've seen an unsettling number of state-sponsored campaigns, or as we call them, crackdowns, in which LGBTQI persons become swift and immediate targets of persecution. At the same time, we're facing a global refugee crisis, where there are now 80 million people displaced around the world. This is the highest number since World War II. And let me be clear, this crisis is not due to refugees themselves who are trying to flee war, famine, or conflict, but by government's failure to act. This situation is hindering a response to HIV. We know now that there's a clear link between LGBTQI criminalization or a lack of human rights and an effective response to HIV. Where legal protections for LGBTQI persons do not exist, many are rejected from their families and become homeless or in precarious housing. Many are fired from their jobs or cannot find work. Women experience violent corrective rape and other forms of sexual violence, exposing them to HIV. Trans folks are often victims of violence. Because of fear of being outed, some people may not seek testing for HIV, nor treatment for HIV and HIV-related illnesses. All of these issues my colleagues mentioned earlier as well. Now, in many countries, human rights defenders and small grassroots organizations provide a lifeline of support to individuals at risk. However, these individuals and organizations often become victims of violence as well. In some countries, it's impossible to even establish a network. The result is an environment where LGBTQI persons often face life-threatening situations where the only option is to evacuate. However, for those needing to escape and flee due to persecution, neighboring countries often exhibit patterns of violence that are similar and similar discrimination directed to LGBTQI persons. For example, when people flee across borders to neighboring countries, refugee camps that provide basic necessities to displaced persons are often dangerous places for LGBTQI people. Moreover, many host countries that are actively already trying to manage their own HIV response are often unable or unwilling to provide the HIV-related services refugees need and to which they have a right under international and human rights law. Despite improvements in the availability of antiretroviral therapy, often refugees do not have access to it. Displacement of LGBTQI people from their country of origin has had an enormous effect on their lives, as well as the lives of host communities. However, an increased risk of HIV infection and poor access to HIV prevention, treatment, and care can and must be avoided. Rainbow Railroad provides pathways to safety for individuals facing imminent danger. Working with human rights defenders since 2006, we have helped over 1,000 LGBTQI people relocate and have provided resources to thousands more of LGBTQI persons facing persecution. This includes emergency relocation interventions in multiple countries where state-sanctioned crackdowns on LGBTQI persons have existed. Our work, fueled by human rights defenders, just underscores the need to address the human rights barriers that are hindering our collective goals to eliminate HIV. So to conclude, in order to address these barriers, there are 3 things governments must do. Governments must decriminalize sodomy laws and other laws that criminalize same-sex intimacy. Governments must uphold the human rights of LGBTQI persons, as well as provide adequate supports for the protection of human rights defenders. And governments must make meaningful efforts to address the global refugee crisis by partnering with human rights defenders and civil society organizations. These actions are key to achieving HIV outcomes. Thank you.
Thank you so much, Kamali. I'd like to mention that Minister Brown has had to leave the session due to important issues, but we're now going to go into the segment of this panel that deals with video interventions from many of our important civil society partners from around the world. The first video is from Ruth Bergen. Ruth is the coordinator of the Women and Harm Reduction International Network. She is a woman who uses drugs, who has advocated for health and other rights for people who use drugs since the emergence of the HIV epidemic. Would you now cue the video from Ms. Ruth Bergen?
We know that KPs face disproportionate rates of violence, which increase HIV risk and vice versa, leading to compounding negative health outcomes among people who are already marginalised and further exacerbated by punitive laws, unequal gender roles, and limited economic opportunities. GBV particularly impacts women, and primary HIV transmission modes among women are unprotected heterosexual sex and shared equipment in injecting drug use. We hear of the commitment to leave no one behind, and still left behind is exactly what has happened to women who use drugs, who face around 25 times more violence than other women from intimate partners as well as from law enforcement officials. Stigma, gender inequality and criminalisation combine to create conditions where violence is not only common, but allows perpetrators to act with impunity while fueling HIV transmission. Ahead of the high-level meeting on AIDS, RIN urges governments to recognise the acute need to dismantle punitive laws for possession of drugs and sex work, and commit to prioritising syndemic mechanisms linking the epidemics of GBV and HIV. To support these aims, the political declaration must recognise the centrality of KP community mobilisation and commit to increasing funding for community-led programs as critical to reducing both violence and HIV. Thank you.
Thank you so much for showing that video. The next video that we're going to show is from Anad Rendon. Renad is the program officer at APCOM. He oversees the implementation of several programs, including community-led research, community engagement with the Global Fund and PEPFAR, community-based monitoring and technical assistance. With a legal and human rights background, he is also involved in policy, advocacy, and human rights documentation. He originally hails from the Philippines and is one of the few Penoys who does not know how to sing. He self-identifies as a gay man and a person living with HIV. Please play the video from Mr. Randan.
The topic of my intervention is not new to everyone. We hear this every year. The structural barriers, widespread stigma and discrimination, and criminalization impacts the key population. These prevent their access to healthcare and other services. The importance of community-led interventions have long been established by UNAIDS and WHO, among others. Our interventions build direct personal relationships, we have understanding of the context, and we invest in the welfare of our community. Community should never be understood as people who are less qualified or less capable. With the global assistance and pledges of domestic investments, sustainability has become the it word. Does sustainability mean having enough money and that we are reaching more targets this year than last year? A study finds that a sustainable HIV response goes beyond finances. It also includes investments towards initiatives that protect key populations from stigma and discrimination, advocacies to remove punitive laws and policies, and activities addressing gender inequalities, among others. The issue of structural barriers is perpetual, that discussions around it become repeated. I fear that in time, the phrase structural barriers to access will become a jargon, void of meaning. But we must not let this happen. We will repeat this every year if necessary, until we are successful in allowing ourselves and our community to freely access these services so we can live a life not governed by fear. To UNAIDS, PAFAR, and Global Fund, may your investments not only place on numbers, but also on human lives. We have witnessed several successes where we have won over these barriers. But we have not gone this far to only go this far. My name is Inada Bakong, based in Bangkok, Thailand. I am a person living with HIV. It is my personal hope that the next generation will not repeat the discussions around this issue, because we have successfully addressed it in ours. That is all I have. Thank you very much.
Thank you so much for that video intervention. We're going to take one more video and then perhaps go to a couple of questions. We do have 3 more videos, however, for this panel, and we're hoping to be able to screen all of them. The next video is going to be from Sasha Volgina. Sasha Volgina has been HIV positive since 2000. She's one of the co-founders of Front AIDS, the first treatment advocacy movement in Russia, co-founded in Svecha, one of the first community organizations. In 2005, she received the MTV Russia live work for her work with the media. In 2007, she received the Carol and Travis Jinks Award, which was presented each year to a current or former drug user who has made an outstanding contribution to reducing drug-related harm. In 2009 to 2010, she co-founded the first all-women's network, EVA, and co-founded an organization, Patients in Control, a treatment access movement, which received the Red Ribbon Award for advocacy campaigns against the stockout of antiretrovirals. May we now cue the video from Sasha.
The declaration should not only describe the vision, priorities, policies, and plans of governments, but should also reflect the needs of people and communities most affected by HIV epidemic. It should also see our populations as equal partners and part of the solution, not the problem. The first and essential step that should be done is to list all the key populations by name, to stop the existing disregard, ignorance, and discrimination of key populations, which will improve the space for advocacy and cooperation between governments and key populations. Secondly, declarations have to be focused on criminalization, as it prevents our communities from accessing prevention, treatment, and care, and prevents us, community-based organizations, from being equal partners for our governments in HIV response. We have to stop being criminals in order to become partners. Let me show why and how we can fail to end AIDS using the example of my own region, Eastern Europe and Central Asia, and my own country, Russia. Belarus, Russian Federation, Tajikistan, and Uzbekistan are criminalizing people living with HIV. Homosexuality is criminalized in Turkmenistan, Uzbekistan, and penalized in Russian Federation. All countries of ESA region criminalize drug use, and all the countries criminalize or penalize sex work. We all know the result. ESA is one of the two regions where numbers of new HIV infections are growing, especially among key populations. And it's not enough just to declare elimination of stigma and discrimination and decriminalization as general condition, but specific and measurable targets and results have to be in place. Clear commitments and mechanisms of political and financial support for implementation should be included. As there have been too many declarations, policies, documents that remain only on paper. The new political declaration should recognize that restrictive, discriminative, and criminalizing laws and practices should be eliminated in all the settings, such as education, workplace, on community level, in humanitarian and emergency settings, in healthcare and legal area. We need an intersectional, action-oriented and comprehensive approach. Dissemination of the best practices and lessons learned by countries and communities. And we need to properly measure our progress in the human rights area. In order to move from words to action and achieve real impact and start equal partnership and cooperation with the community-led responses, the new political declaration should focus on the strengthening and integration of community-led responses as an essential component of national policy and program implementation. In order to become strong, we need a favorable legal environment, including freedom of association, so that communities can freely create and register non-profit organizations, receive public and donor funds, concrete financial and technical tools, targets, and steps to strengthen community-led interventions. National and international mechanisms must be improved to ensure community-led groups and organizations are properly funded. Accountability, monitoring, and reporting mechanisms should be strengthened to ensure regular feedback and communication with communities on delivering the outcomes of the declaration. We, as community-led organizations, are committed to work on ensuring that the new political declaration on HIV and AIDS is not only developed as an effective guiding tool, but also implemented in order for the words to turn into the reality and of saved lives and well-being of people and communities.
Okay. We're now going to move to some questions. Trans women are one of the most targeted communities in our global HIV community. How can governments move forward with creative, strong legislation that supports transgender people and other key populations while mitigating strong right-wing opposition? I'll throw the floor to Marcela Romero. Marcela, would you like to take that question with the response? Do we have Marcela on the panel still? Perhaps someone else can come in on that.
Hola.
Hello? Hello, says the Spanish. Hello?
No se escucha nada.
I can't hear anything, says the speaker.
Acá, ¿qué están escribiendo? Marcela. Te piden que hables.
Here. Please. Can you come in?
Si pueden repetir, decirle porque se escucha.
The speaker is speaking.
Of what can be done to bring forward creative, longer-led.
Acá no se escucha nada.
The speaker wasn't hearing what the chair was saying.
Sorry for the difficulties. I think we have yet to hear from one of our other speakers, Kamali Powell from the Rainbow Railroad. Oh, I take that back. We have heard from Kamali. We have another question here. Perhaps I can throw this question to Kamali. We need to talk about prisons and police violence. Why are we not talking about it enough with regard to the HIV response? We need to be looking at other models for support of communities to grow their protection instead of engaging with police forces and criminal law. How can we better support and advocate for people who are living with HIV, who are incarcerated? So is that question clear to you? Maybe you can address how criminal and legal reforms could help people living with HIV, especially criminalized key populations.
Yeah, I'm happy to try to attempt to answer that question. You know, certainly it's a really important question, and we should all be concerned around the treatment of folks who are incarcerated and access to health services. I think that's the first key thing. And as I mentioned, my an organization that I used to work for and very much fond of, the HIV Legal Network, has worked for years to advocate for the access of health to services for people who are incarcerated, and many other organizations and advocates doing the same. So I think definitely First Stage is pushing for the drive for effective HIV treatment. And I should also just say not only HIV treatment, but other access to medications, including harm reduction services for people who use drugs. And we see in countries that criminalize same-sex intimacy and either global north countries that there is inequitable treatment of folks who are incarcerated, and that's only exacerbated by COVID-19, where because of the inhumane treatment of folks in prisons, the pandemic was able to run rapid. So an effective response really does mean dealing with the systemic barriers of prisons, and ultimately in wealthy countries, dismantling the huge, powerful prison industrial complex. So that would be my answer to that question. Now, I will say, just to the other question, of course, I'm not a member of the trans community, so Marcela is the best person to speak to it. But movements to ensure human rights for trans persons, governments have to listen to interventions led by trans-run human rights defenders and organizations. And as civil society, we have to empower and stand in solidarity with those human rights defenders advocating for trans rights.
Thank you so much for your remarks. Now I'd like to propose a question to Richard. Richard, maybe you could share some of your thoughts with regard to efforts to decriminalize key populations in Africa. We know that it is a big problem throughout the world, but we know you've been involved in SMUG, which has taken a number of steps and provided great leadership in addressing criminalization of key populations. Would you like to share your thoughts on where the community may go forward to try to ensure that the human rights and access to healthcare, especially HIV care, reaches all key populations in your region?
Thank you so much, Eric. First, I want to say the issue of criminalization should not only lie on communities to do something so that decriminalization happens. I think for decrim to happen, we need to also have our governments take necessary steps to ensure that, first of all, colonial laws or the colonial legacy that continuously impacts on our communities is dealt away with. Because most of the criminalizing laws are laws that were left by the colonial legacy. And I think we need to have a discussion around ensuring that laws that criminalize key populations are dealt away, and governments should be open to this. But having said that, for communities, one of the issues that usually comes up is the issue around evidence. Where is this happening? Are you sure it's really happening? So I would really encourage communities to document human rights violations that are happening in their communities, and thereafter engage with their different stakeholders like police, Ministry of Health, but also to ensure that members of parliament also get to understand this. So I think the issue around documentation is really key for us as a community to ensure that we bring to book all the violations that are happening. But also, as I conclude on this particular aspect, I think, again, I'll call upon governments to take the necessary steps because we have seen that strategic litigation has been one way where we have been able to create a space that brings a conversation around decrim. But if that's not happening, if courts of law are not open to communities, then it will make it difficult to actually have a conversation around this. But also, lastly, while we see criminalization of key populations, we're also seeing governments, again, coming in to criminalize people living with HIV. Again, this is something that we also have to deal with. So if we talk about decrim, we should talk about decrim for key populations and people living with HIV. Thank you.
Thank you very much for those remarks. I'd like to turn to Reverend Grayling, if I could, and ask him if you would share, Reverend, what you feel the faith community could do to better support decriminalization efforts, but also to ensure that everyone is able to ensure their right to health and that their human rights are protected.
Right. Thank you very much, Eric. I think the important part that we've learned over the years of engaging as faith communities on HIV and breaking down stigma is that you need to engage from faith communities with faith communities on the issues where there's perhaps not agreement on, and allow the faith communities to struggle with it. And that very often happens in the smaller environments where there's a safe space, where these conversations can happen, and to be able to listen to the experiences of key populations of people affected by HIV. And through that process to identify the areas where communities can engage on together with policymakers to address these issues. So I want to really say that as faith communities, we realize the role we can play to intervene with the communities we are part of and to be the voice. Also to raise the issue that everyone has the same dignity and deserves the same treatment as anyone else, which is the principles which the faith community hold on to. And we are committed to work with you on doing that.
Terrific. Thanks for those remarks. I'm going to throw a question open to the panel in general with regard to sexual reproductive health and rights for seniors. Seniors are sometimes thought as a key population, and I happen to be a member of that population. Would anybody like to come in with regard to how we can make the sexual reproductive rights of elder people be recognized as valid, recognize that seniors still are sexual beings, and that we are sure to target with prevention methods, with right to testing, and with the right to treatment for senior populations. Would anybody like the floor? Perhaps Reverend Grayland, I hate to come back to you again, but you are a gray-haired senior like me. Do you have any thoughts about this issue?
The grey-haired folks around the sexual reproductive health services. I must say that this is an excellent question, because we very often only think about the sexual health services for teenagers and young people. And to just raise this issue as something that I think we must continue to insert into our communications and our strategies, and make sure that the senior citizens, our older people are also still sexually active and need to be able to access the services that make sure that they can have life in its fullness.
Thank you very much. I think Richard had raised a hand and wanted to come in on this issue. Richard, do you have some thoughts you'd like to share?
Yes, thank you so much, Eric and Reverend. I think I'll just say quickly that we need to deal with a stigma, and I think it's the whole issue of stigma and discrimination, where people feel that people of a certain age should not be participating in certain activities, or they should not be part of a certain conversation. And I think if we are to lift that aware, then people of age should be able to freely have access to SRHR services without feeling necessarily that they're being judged. And I think that's one way we have to take this, that people should be allowed to freely have access regardless of their age, their sexual orientation, and gender identity. Thank you.
Thanks so much. We're now going to try to see if Marcella can come in. Marcella, can you hear? Would you like to take the floor?
Yes, I can hear. The issue of reproductive and sexual health in persons who are senior citizens. Well, I think for the elderly population, what's necessary is to modify programs and include, in the case of trans people, for example, we don't appear at all in the programs, and most prevention programs or HIV programs, it seems like trans people are born at 18 years of age, and we do not reach the senior age of senior citizens. But actually, the Latin American trans population, a woman of 40 years of age, a trans woman, is already a mature woman. So, as I said at the beginning, what we need to do is open things up and work from childhood through adolescence and all the way through adulthood to the senior citizen level. Because basically, what happens right now is you just work at the age bracket of 18 and above, not below that. And we need to talk about how we enjoy our sexual lives, and we need to think about breaking down and sort of decolonizing everything, removing the clutter in our heads, the guilt, in the case of trans people living with HIV, many of them feel like it's punishment from God. They feel guilty to be living with HIV. And so it cancels out, they cancel out their own sex lives. So what's necessary is to work on these programs, work with the trans population, especially with older adults, and have them understand that desire never comes to an end. And it's perfectly fine to continue to have sexual relations. And part of the ongoing quest of pleasure and desire is part of life. And so we need to change the program and the focus of them. Thank you.
Thank you so much. I'm afraid we've about run out of
Gracias.
time for this panel. Apologies again to Mirta Ruiz Diaz for the technical difficulties that excluded her from this panel. I feel horrible about that. I want to remind everyone that we're now going to have a break. Panel 3 will convene at 3 p.m. New York time, that's Eastern Daylight Time. So please enjoy this break. We'll see you again at 3 p.m. New York time. And there are 2 panels and a closing ceremony that will run from 3 p.m. to 6 p.m. Thanks so much.